Here is a video presentation of partial pancreatic tail-preserving subtotal pancreatectomy as a viable alternative to total pancreatectomy for carcinoma of the head of pancreas extending to left of the portal vein involving the body of the pancreas. The highlights of this video are the preservation of pancreatic parenchyma to retain endocrine function in lieu of a morbid total pancreatectomy without compromising oncologic outcomes. Staple transection avoids a potentially morbid post-op pancreatic fistula in a patient with a friable and soft pancreas. Is a 54-year-old lady in good performance status with jaundice and upper abdominal discomfort. She was evaluated and found to have an adenocarcinoma of the head of pancreas. She was then explored based on imaging suggestive of operable disease. However, there was disease to the right border of the superior mesenteric artery, and we performed a hepaticojejunostomy and backed out. She received 4 cycles of gemcitabine nab-paclitaxel to full dose and was then reassessed with the normalization of the CA 19.9 levels and an excellent response on the triphasic contrast enhanced CT scan done at the completion of 4 cycles. She was then counseled in detail and consented after a tumor board discussion for a diagnostic lab with intent to perform a classic curative Whipple operation. Operative findings for the lady with borderline resectable pancreatic cancer explored following 4 cycles of neoadjuvant chemotherapy. The portal vein, as you can see, has been identified and the neck of the pancreas suspended. Distal stomach has also been transected in preparation for the Whipple. The relevant anatomy is demonstrated prior to pancreatic transection. Seen here are the suprapancreatic portal vein, the hepatic artery proper divested of all tissue, and the stump of the gastroduodenal artery ligated flush with the hepatic artery to maximize the margin since the GDA was involved on preoperative imaging. The relevant venous anatomy is demonstrated here. The portal vein is seen formed by the union of the superior mesenteric, the inferior mesenteric, and the splenic vein. The pancreatic neck has been divested of the splenic vein in preparation for transection. The pancreas had to be transected through the mid-body, leaving a friable atrophic stump. We proceeded with the staple pancreatic transection without anastomosis. This technique of staple transection was originally described by Dr. Goro Honda from Tokyo. It involves extensive mobilization of the pancreatic body from the splenic vein, following which an endo-GI stapler with a 60 mm blue load is placed across the site of transection based on the thickness and breadth of the pancreas. Gradual graded compression is used till 6 minutes when the stapler is fully clamped. After waiting an additional 6 minutes to allow the pancreatic parenchyma to be maximally compressed and ensuring that all edema fluid is driven out, ensuring a smooth transection, the stapler is fired. The relevant points are enunciated in the slide here for a better understanding of the procedure. Once 6 minutes have elapsed, the stapler is fired in aliquots of 15 mm, allowing 2 minutes to elapse between each firing. Here the first firing has been completed and we are waiting for the mandatory 2 minutes. Then comes the second firing and another 2 minutes. This waiting time ensures that the staple line is further hemostatic and ensures a perfect staple transection of the pancreas. This is the third firing, after which we wait for another 2 minutes before releasing the staple. Thus takes about 6 to 8 minutes to complete the transection depending on the length of the stapler used. You can see here that after releasing the stapler from the pancreas, we have a beautiful, smooth, hemostatic transection line of the pancreas. Duct is usually not identifiable and the stump is reinforced with horizontal mattress rheoproline to aid hemostasis and prevent a pancreatic fistula. Post-transection, the staple line is seen to be perfectly hemostatic and presents a surface which is easy to reinforce. This technique of parenchymal preservation maintains endocrine function, unlike in a total pancreatectomy. Exocrine function is seamlessly maintained with synthetic supplements. The relevant vascular anatomy after a staple pancreatic transection is demonstrated here. You can see the infrarenal inferior vena cava after retraction of the superior mesenteric vein, the rule loop of the previously performed hepaticojejunostomy coming through the retrocolic route, and the venous anatomy showing the confluence of the superior mesenteric vein with the inferior mesenteric vein and the splenic vein forming the portal vein proper, the common and proper hepatic arteries with the stump of the gastroduodenal artery, and the celiac trifurcation, and the stapled end of the pancreas, which is nicely hemostatic. In the left upper corner, you can see the stomach remnant, which is vascular with its vein and artery demonstrated here. After retraction of the superior mesenteric vein with the vessel loop, one can see that the right border of the SMA here is well delineated after total uncinectomy. It has been a radical curative operation, classic Whipple for this patient after neoadjuvant chemotherapy. Staple transection of the pancreas allows for simultaneous parenchymal transection and duct closure, reduces blood loss, and markedly decreases the incidence of POPF. Now, the pancreas is ideal for a soft, friable pancreas with a narrow anteroposterior diameter. The essence of staple transection of the pancreas is patience. Graded and gradual compression of the pancreas with pause between firings ensures a perfect outcome. Staple transection of the pancreas is an elegant operation which achieves a safe outcome with a low incidence of post-op pancreatic fistula without compromising oncologic principles. It is an essential tool in the armamentarium of the pancreatic surgeon as he gains or she gains more experience, especially in the era of minimally invasive surgery, laparoscopic, and robotic approaches.